Welcome. My name is Catherine Baker. I'm director of the UC Student and Policy Center, this wonderful building of activity and engagement and students, which we're very happy to see here today. And I'm grateful to have the opportunity to welcome you to today's Wednesday speaker series on a topic that is timely and from a speaker who has not only expertise, but has had a real impact on legislation that was just signed this cycle by the governor after engagement at the UC Student and Policy Center, actually the UC Center Sacramento program that has historically been here. It's a wonderful, robust student internship program and coursework that we have housed here out of the center. I want to thank Dr. John Marks, the interim director of the program in the back. I know you're back. You didn't know I was going to introduce you, did you? And also Cindy Simmons and her team for putting together a great panel for you today, a great presenter. The talk today is going to examine evidence behind popular treatments for substance use disorders. And it's going to be exploring the reasons why people who are struggling with those disorders relapse and don't seek treatment. Also, we're going to hear today about what those cycles of relapse and recovery might look like for people who are struggling with substance use, as well as what are some policies that may benefit them to get involved in intervention through treatment. And you couldn't have a better speaker from the University of California. Amy Moulin is Associate Professor in the Departments of Emergency Medicine and Psychiatry at UC Davis Health, a world-renowned institution in the entire world in medicine. We've got a lot of folks here who come and speak from UC Davis Health, and we're grateful to have her. Her work focuses on behavioral health interventions and health policy related to substance use disorders. And the trivia I will share with you that I highlighted a moment ago is a few years ago, she was a speaker in the UC Center Sacramento speaker program. And there was a legislative aide from across the street in the Capitol who then reached out and engaged with her on the topics that were being discussed. And Assemblymember Eloise Reyes from San Bernardino County area, then after a couple of years of work with Dr. Moulin, authored legislation to remove the requirement for pre-authorization for substance use treatment. And that was signed by the governor just this year, like last month. And so that's why you have one of the best speakers you could possibly have on a timely topic, and it's someone who makes a great difference. I think it's also a testimony to the programming that happens here through the UC Center Sacramento initiative that we have. And with that, I'd love to introduce you to our guest. Thank you.
Thank you. So I was tasked with talking about all of the evidence for and against drug treatment. Really tiny topic. So we're going to go through some of this. I'm hoping that it goes well. Y'all are going to have to bear with me. And we're going to go through this journey of the history of drug treatment in this country and try and sort out what does and does not work so that we can move forward as a state and as a country. So we're going to talk about clinical and public health interventions for substance use disorder. Really dense topics. We're going to talk about the social and neurobiology models of addiction. They're kind of at war with each other. We're going to try and untangle it. We're going to talk about some clinical evidence-based treatment models, and then at the end, talk about what we really need, which is that public health approach of how we are able to get treatment to everybody who needs it in a way that they can access it in a way that is therapeutic and equitable. No problem. Easy peasy, right? Bear with me. So just a little bit about, you all know this. This is the story of the overdose epidemic in this country. This is a story that we are familiar with around the profit-driven oversupply of opioids from the pharmaceutical industry, a rapid reactionary pullback where people who had become tolerant to the opioids that were highly prevalent were removed with nothing left for them. And then at that moment, fentanyl, which is a highly addictive, highly lethal substance, became highly prevalent, filled the gap, a pandemic. And so we have seen in this country exponentially rising overdose deaths until finally maybe some good news where we've maybe plateaued, start to come down from 111,000 deaths to 103,000 deaths. Still astronomical numbers, but a little bit of good news. But here's the piece for this, is all of this landed on a treatment system that was wholly unprepared for it. That the drug treatment system, and what basically this happened and what fentanyl exposed was a drug treatment system that is uncoordinated, not evidence-based, difficult to access in this country. And so the other piece of good news is that that was exposed. And so at least at this moment, we're starting to have or had some of these conversations around how do we provide treatment to people with substance use disorders. So that's my glimmer of good news in what has been a really tragic story of human loss. So going back, California, always a leader in the nation, is really one of where the social model of drug treatment began. In California, through the 1940s, which I think was the very beginning of sober living houses, which have proliferated, that model proliferated in California through the 1970s. And what this was a grassroots, peer-driven way to address substance use disorders. And people formed these communities, these therapeutic communities on their own. This was not something that was driven by medicine. This was driven by the communities. They developed this to support people with addiction. And so this is kind of through this model, this grassroots, community-driven organization, we have sober living houses. Out of this effort, we have AA and that 12-step model, which was really filled the gap of how do we provide addiction treatment, because there was nothing. So these are groups of people who came together to support each other into recovery, and they developed this model on their own. And really one of those things is, I love this statement, you alone can do it, but you can't do it alone. And this is sort of the model of that social model of addiction. And that really what needs to happen is that social support, peer-led recovery efforts. And so we're going to talk about, like, from a science perspective, how effective is that, and where does that fit into our treatment ecosystem? So I'm going to say this at the outset. Everybody has a unique experience that is valid. So whereby some of these efforts might work well for individuals, what I'm going to talk about are population-level studies and how well do these interventions work for people at the population level. That is not to discount what any one individual's experience has been or what that person's journey through recovery has been. We're going to talk about what does the data say at a population level. So residential treatment, this is that we took in the United States that model of this community-based peer support community that people became a part of. And we changed that to the popular model of how we treat addiction in this country, which is essentially you go to a beautiful house in Malibu for a couple weeks, and your life is changed and you're cured. So we took that sort of beautiful community-based model, corrupted it, condensed it into a couple weeks in Malibu, and that is sort of how Americans believe that drug treatment should happen. That sort of, you go away to rehab, it is something that you do elsewhere, and then you come back and everything is different. So if you look at that model, which is primarily around 30 and 60-day residential treatment, certainly while that individual is in that residential treatment, they're usually compliant. And so 30-day and 60-day rates are better when you live in treatment than when you have to go to treatment. Beyond that, there's no difference. So there's really no difference between a residential at a population-based level and an outpatient treatment model. There are benefits for unhoused individuals. So if someone where housing is a big problem for them, being able to support them through housing. The caveat is residential treatment is frequently not housing. It is usually temporary, 30, 60 days. So if that person is not given housing on the back end, all those benefits are lost. So it's really not about the residential treatment, but about housing. This is another study looking at housing and residential treatment and how housing is important. So the top two lines are days abstinence, the percentage of people who are abstinent, who are no longer using drugs. This is a population of people who are using stimulants, so non-medication treatment, but really around that peer support model and housing supports. The people who did the worst are the folks down there who received no housing. The other two lines are both abstinent contingent housing, so sober living, you have to not use in order to continue to be housing, or non-abstinent contingent housing. Both of those work. So really the key here is not the residential treatment for unhoused individuals, but access to housing. This makes sense. And so really to think about, it's not the residence, it's not the treatment that happens in the residence, but the fact that you have a residence that helps our unhoused individuals. The other one is commonly 12-step programs. How many of you have heard of AA? This is also common, 12-step facilitated programs, really focused on that peer support, in wrapping that person with peer support, creating a new community, a new social community for that person to recover. Versus, these are some studies looking at cognitive behavioral therapy versus 12-step programs. And really interestingly, 12-step programs perform slightly better than cognitive behavioral therapy at 1-year retention, 42 versus 35%, with some decreases in relapse rates at 1 year. So we do see improved retention to treatment at 3 and 6 months, but not really a difference at 1 year. So part of this also, I just wanted to level set. When you hear these interventions are 30 to 40% of people are still in treatment at 1 year. Seems low, right? Makes you feel like, hey, this is really not effective. Like only 30% of people are impacted. What are you all doing? So just wanted to level set. These are 1-year retention in treatment for high blood pressure, for asthma, for diabetes, and it really hovers around 60 to 70%. So the real answer there is Americans don't take their medications and don't follow up with their doctor. That is just that baseline. So if I ever get to 60% treatment retention rates, which is what we often see for people with opioid use disorder who are on medications, that is about as good as we get, right? That is better than people who have diabetes who are their compliance with insulin. It is hard to take medications and it is hard to go to appointments. This is going to be a common theme of this talk, and Americans don't do it. So these are kind of our baseline rates. So when you hear treatment retention rate of 35%, that's better than 0. So a lot of medicine is, how do we move you incrementally forward? There are very few interventions in medicine that get you to 100%. There are very few interventions that are as effective as medications for opioid use disorder. So we're going to get there too. So moving from that social model that is peer support driven, that is around peer support, motivation, individual counseling, that recovery community, creating that new social network, to the neurobiology of addiction. So what we have learned in the intervening, since folks in Malibu were forming these communities, is down to the receptor model of how addiction works. So I can tell you where the nucleus accumbens is, the collection of cells, how they are responding to various neurotransmitters, and how that drives choice and how that drives addiction. So at this point, we know exactly what happens, and that is in that collection of cells, that response to dopamine that people receive from a drug that has that really high response to dopamine and how the brain responds to say, I need to have that response to dopamine again, that can overcome higher level decision making so that the brain's drive to access that dopamine will overcome that person's social relationships, their sense of responsibility, that the brain will, that faulty decision-making process based on these pathways will overcome all of the frontal lobe decision-making process. We know where that happens, we know the targets, we know the neurotransmitters. So this very technical understanding of brain chemistry has developed in the meantime. But to be honest, people are social beings, so it's kind of a combination of both. So specifically, when we develop drugs like buprenorphine or methadone, these are very specific drugs that target those specific transmitters that are causing addiction in the brain and treat them. So buprenorphine in particular is highly effective partial agonist, will bind that receptor that is impacted by opioid use disorder, turn the volume down, and control those cravings and withdrawal symptoms. Highly effective, and what we see is a huge benefit on mortality. So for me as a physician, one of the great tragedies of the overdose epidemic is that I have a highly effective treatment that treats overdose, that treats opioid use disorder. And so the real tragedy is how much we actually know about how to treat opioid use disorder is, for me, the real tragedy. So again, this is looking at medications for opioid use disorder. Because we have these highly effective medications, this is looking at the probability of overdose. So if you see the top line, those are folks who are on medications. So buprenorphine, methadone, and you can see their rates of overdose is much different than the folks on the bottom line. These are all different treatments. So the top, most effective medications. The other treatments are behavioral health treatment, outpatient treatment, residential treatment, versus no treatment. And what we know, because we understand the biochemistry of the brain, we know that buprenorphine, methadone decreases overdose rates, decreases death in a way that the other treatments do not. So for me, this is what I spend my life doing, getting folks into buprenorphine treatment because I know that it works and the evidence shows that it increases retention, increases treatment, and ultimately saves lives, which is what we are all looking to do. Looking at our legacy systems, so remember, what is the predominant model of drug treatment in this country? It is residential treatment, that beautiful house in Malibu, you go horseback riding, bond with the horse, and that is going to solve your addiction that has developed over years. This is a study that's a little bit old, was published in 2020, but was a survey of residential treatment facilities. 70% did not offer FDA-approved medication treatment for addiction. So 70% of the predominant model for drug treatment in this country was excluding some of the interventions that we know are most effective. So when I say that the overdose epidemic landed on a treatment system that was wholly unprepared for it, this is what I mean by it. This is specific. And then if you look at this, I thought was also very instructive, is a review. So they looked at the world's literature over the past 48 years and looked at psychosocial interventions versus medications for opioid use disorder and found in comparison there was very little evidence for the effectiveness of psychosocial interventions versus medications for opioid use disorder, despite the fact that that is the predominant treatment that is offered to people. And so you kind of start to see where we have gotten ourselves into a point where over 100,000 people were dying every year. And then moving on from opioid use disorder. So opioid use disorder, very specific because we have such highly effective medications. We do not have as effective medications for alcohol use disorder, but we still have medications that we can use for alcohol use disorder. However, only 1 in 10 patients with alcohol use disorder are treated with medications. Actually, only 1 in 10 are treated at all, and of those, only half are given access to medications. So the primary medications that have evidence are naltrexone and acamprosate. These are oral medications, can even have a long-acting injectable, and has shown in comparison to treatment without the medications, decreased rates of heavy drinking at 3 to 6 months, and increased retention at year. Both of these medications are effective to treat alcohol use disorder, but highly underutilized. For stimulants, because we're going to try and go through all of this, we really don't have great medications. So then again, we start to rely more on psychosocial supports because we don't have any FDA-approved medications for stimulant disorder. But that does not mean that they don't exist. I also think for those of us in California, there is a little bit of an East Coast bias, right? Methamphetamine is predominantly prevalent and has been for many years on the West Coast. We continue to be the methamphetamine capital of the known world. However, in terms of research dollars, there is a predominance on the East Coast. And so when NIDA and a lot of the NIH looks at research dollars, they have a predilection for folks on the East Coast where methamphetamine is still rare. So a lot of the research is not being done on methamphetamine use disorder. Some of the primary researchers are in San Francisco because that is where the population is, and in Sacramento. So these are some of the medications that have been shown to be effective to treat methamphetamine use disorder: mirtazapine, bupropion, and there's even been some studies on agonist treatment. So remember, buprenorphine and methadone are kind of agonist treatments, so there's been studies to look at things like Concerta, Adderall as replacement treatment for stimulant use disorder that have shown some efficacy. So not to say that we don't have any studies on medications, they're just not FDA approved. My thought is it's because it's a California problem. What is effective for stimulant use disorder is a trick called contingency management. You might have heard of this. This is often referred to as they want to pay people to stop using drugs. That is not what this treatment is. This is a highly effective treatment that leverages the reward pathway in the brain. So people really like a random reward. You can go to Las Vegas and see how effective that random reward process is to the human brain. So what this technique does is has been studied a lot in VA populations. Someone will come to treatment. They will have achieved whatever goal they had with their treating provider. Maybe it was decreased use, maybe it was not use, abstinence. And then because they achieved that, they will get to spin a wheel, gamble, or have some type of random reward. And that random reward reinforces that behavior goal that they achieved. So it's really using those neurotransmitter pathways that the brain really likes around random rewards to reinforce the behaviors or the treatment that person is engaged in. Very effective, particularly for people with stimulant use disorder, has also shown to be highly effective for people with co-occurring mental illness and stimulant use disorder, where other treatments have not been. This is an effective treatment. Okay, so now you guys are experts in addiction treatment, and in the next 15 minutes, I want to switch gears a little bit and talk about how our system and how we can deliver these treatments to the individuals who need them. So here's a pretty damning statistic. So this is from the National Survey on Drug Use and Health in 2023, looking at Americans who had a substance use disorder and who would have needed substance use treatment and how many of them received it. And 6% had received medication treatment in the prior year. So really thinking about like this, about 10% received any treatment and 6% received medication treatment. So our treatment system is nowhere near where it needs to be to meet the needs of our population. So you start to understand why overdose deaths have been driving so high. It is not that it is just fentanyl, it is that fentanyl unmasked a treatment system that is totally unprepared to meet the needs of our patient population. This is another study that I think for me helped to highlight how opioid use disorder and drug use is a public health problem. So this is David Cutler. He is a Harvard economist. You might have heard him on Freakonomics podcast. And he talked about why the fentanyl epidemic has been so prevalent and got as bad as it did. And one of the things that he looked at in his economics term is this thick market externalities and the persistence of the opioid epidemic. What that means is we have a market where there are lots of buyers and sellers. And the high prevalence of buyers and sellers in that market, the high prevalence of fentanyl and people who are using fentanyl through their social networks expand use. So essentially, because you have something that, as it becomes prevalent, through social networks, that prevalence increases the prevalence, and it's sort of this positive feedback and has spillover effects. And they tried to model what the impact of having that high prevalence of fentanyl and the traveling of fentanyl and fentanyl use through social networks, and they looked at this on social media networks and how fentanyl traveled across the country, and tried to model like what would have happened if there were not these spillover effects, if we did not have such high prevalence, and really saw that we would have not seen as much overdose, as much use if we did not have such high prevalence. And so the key here is because we have so much fentanyl, we have so much fentanyl. So because it becomes so prevalent, it is sort of it is a positive feedback loop. Because it's so easy to access fentanyl, more people access fentanyl. Because people know people who are accessing fentanyl, more people access fentanyl. And so it's that positive feedback loop which has been driving this epidemic. And that really kind of thinks about that public health approach around, it's not just about hotspotting, but it's about the entire community and how we can offer treatment to the entire community with that public health approach in order to reach people who need treatment. So just to put this into context, this is California, 10,000 deaths. So these are basically rates per 100,000 population of overdose deaths in California. And then thinking about substance use disorders, so this is a little bit old, 11,000 Californians died from fentanyl overdose, but that's not the whole story, right? Because 20,000 died from excess alcohol use. That number's probably higher because we're not counting all of those use. 1 million individuals presented to an emergency department, had a substance use diagnosis, and only 5% of Americans are seeking care. So really to kind of put this into context of it is a much larger problem than just fentanyl and overdose. But really this is a public health problem that we have not addressed at any sort of system level. Versus, this is my bias as an emergency physician, the trauma system of care. So in California, there were 3,700 car crashes and 1,800 violent deaths in California. At the same time, 10,000 people died from an overdose death. For a trauma patient, I work at a level 1 trauma center at UC Davis. Someone comes in who's had a car accident. From the moment that that car accident happens, an entire cascade of treatment systems are activated. from the 911 call, from an EMS system of highly trained professionals to triage, to provide rapid treatment, to transfer to my specialty center where I have specialty multidisciplinary trauma surgeons, cardiothoracic surgeons on staff waiting to receive that person because they might possibly benefit from an intervention. We have this highly coordinated, time-sensitive, team-based approach where we stabilize that person, admit them to the hospital. Then we also have on the back end treatment, rehabilitation. And so it's an entire system of care that is designed to be highly coordinated. We have preventative efforts around seatbelts, and our entire system is designed to address 3,700 car accidents. And so for me, as an emergency physician, we're trying to take that learnings from trauma. And so my work is really around offering treatments in emergency departments. And so we started California Bridge, which is the program that we have in California. And the goal here is to take that trauma system approach and bring it to substance use. Patients with substance use disorder are universally offered treatment. Buprenorphine is started on demand in emergency departments, and we bring in the learnings from the social model. People with lived experience are incorporated and offer support and navigation to people with substance use disorders. So our goal was 24/7 access to high-quality addiction treatment in California hospitals by 2025. We got about 85% of the way there. About 15% of the hospitals were not excited. But I figured a good B, I'm going to take it. And so what we have seen in California is an increase in the number of buprenorphine prescriptions. And so I think that some of what we're starting to see is we are just starting to get to a place where people can access treatment. This is some of the totals around the impact of our emergency departments. So these are just people who happen to be in the emergency department and offered treatment. 444,000 people were identified with a substance use disorder. Most of those were opioid use disorder, primarily because that's what we are focused on, recognizing that there's twice that number of people with alcohol use disorder in the emergency department, and 138,000 prescriptions for buprenorphine were written, and 271,000 naloxone kits. We did a study looking at people who wanted treatment. So how many of you have heard the reason people are not in treatment is because they don't want it? That is the common myth out there, that people are not in drug treatment because they do not want drug treatment. That's the reason, that they are perfectly happy and that we have to force people into treatment. In our study, of the people we identified in the emergency department with an opioid use disorder and said, hey, did you want help getting into treatment? 86% said, yes, I would like help. I would like help today. If there was a predominance of people out there who did not want access to treatment, I should not be able to walk up to someone who happened to be in the emergency department and say, did you want help? And most of them, 86%, said yes. So this tells me that there are huge swaths of the population who have no idea how to access treatment because nobody has ever asked. So it's that simple intervention. So one of the focuses that we have is on low barrier access to addiction treatment. Because we have had that legacy system of you need to change your life before you can access treatment, that a lot of times our treatment system puts barriers in front of someone. You have to be abstinent in order to access treatment. You have to jump through all of these hoops, go through long assessments before you can access treatment. That you have to prove your worthiness through your commitment to enter into a program before you are offered drug treatment. And what we have seen is that that leads to worse outcomes. That leads to ever-increasing overdose deaths. And so this new model of low barrier, where someone who needs treatment gets treatment, is what we have focused on in our emergency departments and then trying to promote low barrier access clinics. We have seen that people who are offered buprenorphine in the ED are twice as likely to remain in treatment at 30 and 90 days, and those with access to a navigator are 3 times more likely to remain in care. And so low barrier treatment drives demand. So the more people that you offer treatment to, the more people who are interested in treatment. SAMHSA has identified high barrier as one of the problems that looks at these are some of the pieces that are commonly seen in drug treatment programs that are not effective. Treatment programs where goals are imposed on patients, patients who, if they do experience a relapse, are kicked out of treatment. So that person who probably needs a higher intensity intervention the most, that person who's experienced a relapse, is often kicked out of treatment. There are limits on the amount of treatment that a person can get. Medications are often not prioritized. There are limited services, long waits. People often have to wait months before they're able to access treatment. And so inevitably, we see some of the poor outcomes when we offer treatment that is inaccessible to people and not delivered equitably. And so really to think about how do we take the lessons from that trauma system of care and bring it into substance use disorder treatment, and where we can provide access to treatment through emergency departments, through our drug treatment system, the hub and spoke system, methadone clinics, intensive outpatient treatment, integrated outpatient treatment, and ultimately primary care, where someone could receive a prescription for a medication to treat alcohol use disorder at the same time they receive a prescription to treat high blood pressure and diabetes. And that would be the ultimate integration of care. And so to think about how we can expand access to community-based treatment and to meet people where they are in the emergency department, unfortunately often in the state prison system and jails, but to be able to make that an opportunity to bring people into treatment through either low barrier clinics, primary care, or county behavioral health treatment, that we can really expand the population of people who can access low barrier, same day, walk-in treatment that works for them. And so really this is, I think, what I want you to leave with is that this seems obvious. All people should have access to low barrier, evidence-based addiction treatment. And how far we are from achieving that goal, and really the investment that we should make in providing access to addiction treatment. And I'm gonna stop there for questions.
Wonderful. Well, thank you again so much, Dr. Mullen, for this fantastic talk today and these great questions both on Zoom and in person. I appreciate everyone. I did also want to put in a quick plug for our talk next week, which is going to be on public health interventions on tobacco and cannabis. And our speaker is actually sitting there in the corner, Dr. Eliza Tong over there. So it'll be here Wednesday, 12 to 1. And so we hope you can join us for our next talk as well. And again, Dr. Mullen, thank you so much for a fantastic talk today.
Thank you, everybody.